further ado, I'd like to begin the presentation and thank you for the opportunity to present around suicide. First, suicide awareness, so reduction of that stigma, and then understanding through some of the events and initiatives that we have going on, what are some of the tools and strategies that we can put into place if we are worried about someone right now. So I'm just going to take a moment to share my screen. Okay. So I've given the intro and the importance and thanks for including suicide awareness in your conversations for September, particularly because of the importance of this month to the issue. Today, I'd like to begin to unpacking some of the myths and facts. So what do we understand about suicide as an issue? What might we not understand? Some of us listening in today may have personal and lived experience with suicide, and other of us may not. But there's some things we can unpack and understand about who is impacted and why that will be important to place our conversation in today. We're going to talk briefly about some best practices in suicide prevention. There are not many, but there are a few, and they're important. We're going to cover those. We're also going to talk about warning signs, protective, and risk factors, leading into that important conversation of what if I am worried about someone? Where do I even begin to start this conversation? I'll then finish with a little bit more information about the work that we do at the Center for Suicide Prevention, both with our small team of about 14 of us here in Calgary, but how we're supported across the country by a network of trainers and colleagues with Canadian Mental Health Association. And then I'll provide some information if you're interested to learn more. So some more workshops and more information and training. So if that sounds good, we will kick off. So understanding the issues of suicide and suicide prevention. If you can turn into your chat boxes, if you're comfortable, normally we do this in person. So this is always our interactive, put up your hands, classroom style presentation in the before times. Now that we're in COVID, we like to do this through chat. So if you're comfortable and you'd like to participate, you can open up your chat box. I'm going to read out a few myths and facts statements. And after those, I'd like you to tell me what you think. Do you think it's a myth or a fact? And then we'll debrief and unpack what it is. Okay, so that's our game. That's our game show to start off with. So our first myth or fact, I'm going to put that up on the screen for us. So what do you think about this first statement? So globally, more people die by suicide than in war and homicide combined. What do you think? Great, so I can see Margaret's got us straight off. Thanks, Holly. What do you think, myth or a fact? More people by suicide than war and homicide combined. I'll give you a couple seconds there to throw in your chat answer. Okay, well, let's see what the survey says. Well, if you said fact, you were right. So a check mark for you on today's first quiz question. This number, in fact, may be a little bit low. We're thinking now it's closer to 1 million lives, and this is globally. This is around the world. The World Health Organization reports dies by suicide annually. So this is not total. This is every year, close to 1 million lives. And that's more than through war and homicide combined of about 500,000. So when we talk about suicide, we're not just positioning this as an individual health issue. This is not just a mental health problem for one person or one community or one family or one province. Right? This is globally a public health issue. How about our next statement? More men die by suicide than women. So die by suicide than women. What do you think? Is this a myth or a fact? You could go into your chat box and let me know what you think. Okay, survey says fact. And this is surprising sometimes to us, because what do we see in popular culture or social media? We would often think of women who die more, or teenage girls. Well, they certainly are vulnerable, and we have data around more of attempts of women, but we know that historically in Canada that men die at a rate of 3 to 1 compared to women for suicide. So male rates are historically higher, and that's not just in Canada, we see that in other countries as well. Women will attempt more. So women will attempt up to 4 times greater than men, but men will die by suicide at these higher rates and numbers. How about our next statement? So if we think now about age groups, so ages impacted by suicide. Teenagers die by suicide more than any other age group. What do you think? Okay, thanks for putting in all your chat answers. Okay, well, let's see what the answer to this one is. Well, if you said myth, you were right for this question. Building on from the last slide, so we know that men and male rates are higher than women to female at a rate of 3 to 1. When we're talking about the age groups, and I see Michaela gave us an early answer on this, thank you. It is middle-aged men who have the highest numbers of suicide. And that can also be surprising. It's not typically what we might think, stereotypically, what we might think. That age range around 40 to 45 to 60, 64 have the highest numbers of suicide. So why do you think that might be? Put it into the chat or feel free to call it out. Why do you think middle-aged men? What might be some of the factors behind that? Any guesses why middle-aged men? Right? So life stages, retirement, loneliness and isolation, huge challenge. Absolutely. Quality of life for sure. Right? So a lot of things happening at middle age and middle-aged men. Stereotypically and historically, we have not raised boys and men, and we have not made it socially okay for men to seek out help, to show a weakness if they are feeling that they need support. Men stereotypically do not reach out for help as much as women. So that isolation and loneliness is huge. That's right. Someone contributed that. Onset of health-related issues, that's right as well. So when men are isolated or feel, that stereotype of I need to be stoic and strong, or at middle age, I know I should be here, I should have achieved this, and I haven't, that compounds differently for men than women, particularly at middle age. If we have socialized and raised men to not feel that it's okay to show true emotions or seek out help. Women tend to be a bit better at seeking help and support when we need it. Men, and particularly middle-aged men, not so much. One of the other issues with why men and middle-aged men more is because of the use of lethal means. So men will typically use more lethal means than women. But certainly those social, cultural stereotypes around men seeking help and middle age all come into bear. Thanks for that. Thanks for all your contributions. Now, what about this question? And we get asked this one a lot at the Center for Suicide Prevention. So asking someone if they're thinking about suicide may put the idea in their mind. What do you think? Is this a myth or a fact? Great, thank you for that. I think pretty much everyone nailed this already, and that's awesome, because if there is any takeaway from today, any nugget that you want to take from this presentation is this, is that asking about suicide and asking directly may actually reduce the likelihood that someone will attempt. And it's contrary to what we think, right? And the research has shown us that rather than feeling afraid that if we ask or we talk about it, that we're planting the seed, we're putting the idea in someone's mind, as one of my co-trainers often says here, if we've reached the point that we're worried enough about someone that we're asking about suicide, chances are they've gotten there long before we did. We talk a lot in suicide prevention about invitations. Warning signs, yes, but warning signs are difficult because individuals are complex, because we're individual human beings. So what impacts me can be very different from what impacts Chris or other people. But people often talk about invitations, and these can be conscious or subtle, that I am showing behaviors, or I'm saying things, or I am exhibiting things in my life that might point to the fact that I'm thinking about suicide. And research has shown that all I want is for someone, even one person, to just reach out and ask me how I'm doing. So the research has actually shown that rather than planting the idea and putting people more at risk, we're actually reducing the risk. It's a protective factor to ask directly. We're reducing the burden on that person. We're reducing the stigma to have an open conversation about suicide. And we're identifying ourselves as someone who can be talked to and support them going forward. So myth, asking about someone does not put the idea in their mind. So thank you for all those. Now this is an interesting one. What do you think of this one? People who think of suicide want to die. You think this is a myth or a fact? Not always, okay. Yeah. Great, and I can see some of that, sort of questioning on this one. This one is a bit of a different statement. This is born out of research and what we know from survivors, those with lived experience or survivor attempt survivors. What people who are experiencing suicide don't want to die. What they want is the pain of their daily living to end. So it's the idea that getting up day after day to live with this psychological pain is what they want to end. And that's not necessarily the same thing as wanting to die. So it's a really important differentiation. We think about the invitations or warning signs that people may exhibit, and then how do we respond to those? So how do we support someone or begin that conversation, recognizing that it's the daily pain that they're in. It's not that they want to die. So who dies by suicides? This is a great segue into this now. So who are we talking about? Well, I mean, anyone, right? None of us is immune. It doesn't matter where we come from. It doesn't matter our education, our backgrounds, our demographic, our culture, whatever it might be. Any one of us at any point in our life, at any life stage, can have thoughts and feelings of suicide. We're not immune. But with that, we know that there are some priority populations who are impacted in different and significant ways to suicide. We talked about gender earlier, and you may see a pattern here in some of these priority population groups. Young Indigenous men, middle-aged men, older adults, particularly males. We also know, however, the two-spirited LGBTQ plus youth population is also a priority population. But again, the key is that any one of us at any point could have thoughts or feelings of suicide at any point. And the question is why? So why do people die by suicide? And if you have ever struggled with your own mental health or you have supported someone who has, I think we all wish we had a definitive answer to this question. But we don't. And we don't because suicide is complex, because people are complex. We also know from the research that rarely is suicide due to one single cause or one single risk factor. It's rarely not just because of one incident or one event. It's that interaction of multiple factors. It's really interesting in this time in which we're in COVID, when we think about, impact on suicide or impact on mental health, when we're actually seeing over the course of the year, the course of this past year of pandemic, suicide rates have dropped over the country. But that may not be surprising to us initially. Right? That's consistent with what we see with natural disasters, for example. And the researchers and clinicians call this the coming together effect or the pulling together effect. So when we're faced with that immediate disaster or event, we come together to support each other. Okay? And then we have other supports in place, financial. We've seen that in COVID as well, the federal government supports. But then we start to see other impacts relating as well. So we know through reports and surveys done by Canadian Mental Health Association National that more Canadians, and I'm talking significantly higher numbers, are reporting stresses in their mental health. Significantly more numbers of Canadians are reaching out to their helplines, to crisis lines. And that's fabulous. That's a great, great part of this story, that people are reaching out. But then what do we do when some of those supports go away or those other factors come into place? If I'm already feeling vulnerable with my mental health and I have this layering effect of other certain events in my environment or I have certain things going on as well. But it's really important to point that it's not just due to one event or one incident or one risk factor that will make or break someone to think about suicide. It's that culmination, that multitude of factors happening. So suicide is complex, and it's complicated to just link it to just one event or one incident. We do know, however, that people experiencing suicide ideation experience commonalities, common things. This includes that deep pain that we were talking about. So that pain of day-to-day living that's just getting too painful to bear each day. The second thing that results then is that inability to see alternative solutions to problem solve. It's really difficult to think rationally when we're in a lot of pain. We all know that. We all feel that in spades this past year. Stress, anxiety, pain, it can be difficult to problem solve outside of that. So then we get a tunnel vision, and that then results in that reluctance, or quite frankly, that inability to seek out help. We're always encouraging people, seek out help, talk to somebody. That can be hard to do when we're in pain and when we can't see all other alternatives. So we're going to flip the narrative on this a little bit, and we're going to talk about help offering. And it's something we talk about at the Center for Suicide Prevention a lot. Help seeking, absolutely important. Awesome if people can do that, but it's not always possible. We're not always in the right place to seek out that help. But if we can support others in knowing what to look for and how to start conversations and how to offer help, then we're all going to be a little bit safer and a little bit healthier in our communities. Let's look now to put some statistics or numbers into play. And as we know, numbers only tell one piece of this story, and certainly the reported numbers of suicide deaths are just one picture of the prevalence of suicide. There are other things that also paint this picture in terms of suicide behaviors or thoughts and feelings of suicide. If we look at the population of Canada, and this is a bit dated, but it's from Statistics Canada, in 2019, let me just make sure I got the right thing, 2019, yeah. Over 37 million of us in Canada. Reported number of suicides were just over 4,000. But I want to look at some of these other numbers underneath this, remembering the reported numbers of suicide is just one piece of this puzzle. It's one piece of data. It's an important piece, but it may not be telling the full picture. When we look at unreported numbers of suicide, so deaths that may not be classified as suicide, or things like single motor vehicle accidents where it's difficult to determine causes of death, those types of things, they can be 10 to 30% more than the reported numbers of suicides. Suicide behaviors, this is even more significant, 40 to 100 times greater than the number of actual reported suicides. So suicide behaviors, serious suicide ideation, talking about or seeking access to means, for example, or moving into self-harming behavior. Self-harm not being suicide, so not to be confused with suicide, but potentially along a continuum of suicide behavior. I want to reiterate the point again around this idea of help offering. So you've probably heard this number in many other different mental health contexts if you've gone to different presentations like this 1 in 20. So the idea that 1 in 20 or 1 in 5 may be struggling with thoughts of suicide or mental health, and that's significant. So in Canada in 2019, that was around 2 million people with serious thoughts of suicide ideation. So serious thoughts and plans potentially and behaviors around suicide. If that's a 1 in 20, we also have 19 in 20 around that individual who can maybe learn what to look for, how to start that conversation, how to be aware of how do we offer help. So we tend to put a lot of focus on that 1 in 20, 1 in 5, which is important. But then for all the reasons that we've talked about, the pain, the inability to seek out help, that tunnel vision, it's also really important. And maybe never at a time in our society more important when we have healthcare systems who are already burdened beyond their capacity, for those of us in community to start to shore up some of our resources. For those of us in community, in our families, in our workplaces, in our volunteer organizations, to start to develop some of these skills and abilities to reach out and support people before we get to crisis points. And that's really what help offering is about. Okay. And what about best practices? I mentioned earlier there are not many in suicide prevention, but there are a few. The World Health Organization has identified 4 main sections or areas for strengthening suicide prevention. The first is around open and easy access to mental health care. And I would add to that early. So the earlier we can identify, particularly with depression, and the earlier we can seek treatment and get treatment that's needed, particularly for our youth, before situations escalate to crisis points, the better. So that's early suicide prevention, proactive. Responsible media reporting. And interestingly enough, today I'm also speaking to a group of journalism students at Mount Royal University in Calgary, all around responsible media reporting. We know that the media can impact both positively and negatively on suicide rates. So we're lucky in Canada to be supported by a journalism forum that has mindset guidelines for reporting on mental health and how we paint stories of hope and recovery and encourage people to get help and when they need it. Another best practice in Canada is restriction of lethal means. So we talked about men being more prone to use lethal means than women. So this includes things like gun control, medication packaging, and also transit barriers. And fortunately for the organization where I work, the Center for Suicide Prevention, education, public education and training, including research on best practices, what is happening around the country and around the world, as well as data analysis. So what is the experience of suicide in different cohorts and different provinces around the country, and how can we address that? So education being a primary component of a best practice in suicide prevention. So let's talk a little bit about why. So what are some of the factors that may prevent suicide or be a protective factor? And if you'd like to contribute in the chat box, maybe throw some of these out there. What would be some of those positive factors that might protect someone or build their resilience for thinking about suicide? Any ideas? Good support systems, absolutely. Strong relationships, absolutely. Positive factors, community supports, and a purpose in life. Yeah, absolutely. Employment, whether you're employed, you're in school, you're volunteering. Anything else? Your social determinants of health, your pets, absolutely. Yeah, pets can be a great protective factor, really positive for our mental health. I like those. Those are great. You've touched on a lot of those. So that resilience, that personal resilience. So we often talk about mental health. It's not the absence of problems, right? Just because you're mentally healthy doesn't mean you never have a problem or an up and down day. That's not reality. The mental health is a continuum. There's ups and downs, and it's how we navigate through those. So it's how those we access our resilience and our coping mechanisms. Talked a lot about this in some of your chats here. Positive relationships, stable home environment, peer support, that good physical and mental health. So are we taking care of ourselves physically and mentally? Social group involvement and our peer support. That social group involvement is also really important when we think about COVID and the impact that we've had in terms of isolation and socialization, particularly in young people. And accessing support for trauma, absolutely. So speaking of trauma, thank you, Holly. Great segue into the right side of this chart now. So what are some of those factors that might increase a person's risk? What might make us more vulnerable to suicide? And feel free to put these in the chat. So yeah, social isolation. Yeah, absolutely. We were just talking about that. Conversely, when we have positive socialization, that's a positive. When we're isolated, that can be a negative. Stigma, absolutely. Substance uses, mental illness, absolutely. And mental illness is interesting because it doesn't necessarily mean, again, it's not just because we have a mental illness. It's not that one factor or condition that may make us more prone to suicide, but what's happening around us? Are there other factors at play? If we're already vulnerable with a mental illness, could other factors be compounding? Adverse childhood experiences, absolutely. Breakups, relationship difficulties, 100%. Great, thank you for those. You've touched on many of these. So previous suicide attempts or losses, suicide losses, as well as others, particularly if suicide, if we have a lived experience as a suicide survivor, so if we've lost someone to suicide, we ourselves become more at risk, particularly in the next 12 months. The preceding 12 months, we have higher suicide risk ourselves for having lost someone. We talked about mental health conditions, so unmanaged conditions such as depression, really can escalate if not identified and treated early. Childhood traumas, mentioned that as well, substances, and the social isolation. So check boxes on all of those. Did really well. Thank you for your input. All impacting. And again, remembering this is not a checklist. It's not that suicide will be present or a possibility just because of one of these factors. We could have something like this happening in our life and still not think about suicide. We could have different things at play, and that might cause us to think about suicide. It's because we human beings are these complex little individual beings who interact with our world in situations in different ways. Well, thank you for that. We want to talk then about warning signs, and I used the word invitations earlier. So invitations kind of, invitation is usually a positive, right? Remember we used to go to parties and get together, we get invited to things. But invitations in the world of mental health or suicide prevention are these ideas that people are exhibiting invitations. And this can be very direct or it can be indirect. But there's something in our behavior or our feelings or our statements that could be a warning sign that suicide ideation could be present. When we're talking about supporting someone with suicide, it's really not our job to solve their problem or diagnose their condition. There can be a role and an opportunity for a mental health professional or a doctor down the road. But what we're talking about today is just that initial alertness, that initial awareness that something doesn't seem right here and I want to find out more what's going on. That's where we're situated today. With warning signs, however, though, there can be some acute ones. And these are really, this is like the stop sign, like we could need to access some mental health and supports or emergency services. The first, of course, is when we're threatening or talking about dying or wanting to kill oneself, looking for ways and means to do that. And then also talking or writing about death or suicide when that has not been our norm, when that's out of our norm. So those are some of the acute warning signs. And it could be, determining if a plan is in place and then accessing a 911 or other emergency services if we need to. That's almost, the really clear and direct warning signs. There are additional ones. These, again, can vary from person to person. Things like the substance uses, that expression of hopelessness or purposelessness, anxiety, rage. Are we showing different emotions or different behaviors? Are we acting recklessly? Are we giving away possessions? Those could all be warning signs. And again, not that just, because I have a substance use disorder that I'm, automatically at higher risk for suicide. It's that combination of factor. What else is going on for me? Warning signs or invitations. These are things we can be alert to. Really, we know with those complex individuals that we are, is that any change in our normal behavior could be a warning sign. It could be. But our key is to look at the intensity of that. Again, mental health is not just the absence of all problems. It's not just having a carefree, problem-free life. Now, mental health is the continuum, how we move through those ups and downs. We're all going to have a bad day. We all could feel depressed. We all could struggle. But is it intensifying? Is it getting worse? The duration. Has this been going on for a long period of time and typically more than 2 weeks? So over 2 weeks. And is it becoming disruptive? So am I now being disrupted in my daily routines, my daily relationships, my daily life? So the ups and downs of life, absolutely. But changes in behavior, we need to start paying attention to the intensity. Are they getting worse over time? Has this been going on for a longer period of time, maybe 2 weeks or more? And is it starting to get disruptive to my normal and regular routines? Am I not able to do basic general things in my routine? Then we're starting to look at some suicide warning signs. Does that make sense? If you're worried about someone, we do a lot of education and training at the Center for Suicide Prevention. I can talk at the end of the presentation about learning more about these signs, but I wanted to give these at a really high level. And I think it's important we talk about what this can look like. Again, it's important to remember that it's not our job to solve someone's life problem for them. We don't have the tools or capacity for that, and we don't need to. What we need to do is just recognize when someone may be inviting us to talk with them or ask them about how they're doing? And then how do we support and connect them to a trusted person in their life? That's all we need to do. We need to notice what's going on. So something may not be right, or something seems a little bit off. Then we need to reach out. So find a safe and comfortable place for conversation. And that can vary on our relationship, how well we know the person, and how close we are to them. But we need to find a place to initially have some conversation. Mention what we've noticed. So say what we see. Jack.org has these great golden rules, and I love the first one. Say what you see. I've been noticing you're acting like this. You're saying these things. You're doing these things. And it's kind of been going on for a while. Like, how are you doing? How are you really doing? And if we're worried enough about suicide, then we need to ask directly about suicide. The two sort of handiest words or best words when we talk about asking about someone for suicide, because this can be really scary if we've never done this before, is to start with sometimes when. So start with those two words, sometimes when. Because sometimes, not always. We can ask someone about how they're really doing and that we're worried about them, and suicide may not be present. And that's great. But if suicide is present, we need to reduce the stigma, normalize the conversation, thank them for telling us, and then say, I'm not the person to solve this problem for you, but I'm going to stay with you and stand by you to help you identify or get to someone that you can talk to about this. And that's really the support and connect piece. So how are we supporting and connecting? So if we're worried about someone, we're noticing the warning signs, we're reaching out to start a conversation, we're asking how they're doing, and we can use those words sometimes when. Like sometimes when people are going through what you're going through right now, or they're saying the things that you're saying, they're doing things they're doing, they might be thinking about suicide, or they could be thinking about ending their life. Is that true for you? Are you thinking about that? And if we're worried enough about suicide, we have to ask directly. We're not putting the idea in their mind. We're not planting that seed. Remember, that was a myth. It's a protective factor. It reduces the likelihood that they will attempt if we ask, and we ask directly, because we reduce the burden they're carrying and we've reduced the stigma. And then we support and connect. We get them to the help that they need. They may need a mental health professional. They may need a doctor. They may need someone within their workplace or EFAP or whatever it might be that they work with, or their campus, or whatever support that they have available around them. But it's important that we support and connect to help. We educate for life at the Center for Suicide Prevention, and this is our big 4-0. So we are turning 40 this year. So since 1981, we were incorporated in 1981 with a mandate around education. So equipping everyone. We used to say Canadians, but now our borders have opened in COVID and we're training the United States as well. But our focus is on education and training, that best practice through public and education training. How do we give people the skills and knowledge to respond to those at risk of suicide? We began training in 1983. In our 40th anniversary annual report, we've reported over 9,000 workshops since 1983, and we've reached over 160,000 people in our workshops. So that's a lot of training and a lot of conversations. 400 plus workshops annually. So we're going to look at our annual outputs that we do. We reach over 7,500 participants. We support over 400 agencies and organizations, campus partners, private sector, public sector, all groups and all types of organizations. And we're logging over 80,000 training hours per year. We are community educators, and we do this work in two main ways: through information services. So we regularly take best practices and emerging practices from across the country and around the world, and we distill that into resources for the public to access. And these are available for free on our website. We have so many toolkits and webinars and resources. We're also home to the world's largest English language collection of suicide prevention resources in the world. So right here in Alberta, right here in Canada. And that informs the work that we do. As educators, we're also supported in our work by a branch of trainers. We have a network of over 170 trainers who go out into organizations and deliver our training. So we have knowledge-based, skills-based workshop, population-focused. We also offer this in person when and where we can, but also virtually. Our media and communication is a huge tool. And when we have new tools or we have new toolkits or things to release, we often do it first on our social media. So if you're interested in connecting to us, if you haven't already, look for us at CSPYYC on Facebook, Instagram, LinkedIn, and Twitter. So a lot of our information that we push out, those free resources, are available on those channels. Do you want to learn more? If you're interested in learning more, there are opportunities to get deeper into suicide prevention, learn the skills, learn how to start those conversations. These are a few examples of some of the training that we have. The first, the one on the left, is START, which is online. So these first two are actually online or virtual. So START is an independent module, self-paced, about an hour to an hour and a half. You work through modules on your own to begin to start to recognize those signs and understand around suicide. If you're interested as well for small group training, the How to Talk About Suicide webinar is a small group training. So START, you can do individually on your own, self-paced learning. The How to Talk About Suicide webinars are available if you're interested for small groups. And we work through case studies and discussion, and we probe deeper into those 4 steps of what do we do if we're worried about someone. You may also be familiar with Safe Talk and Assist, which is available around the world. So Alberta, Ontario, every province and around the world globally. So Safe Talk is the half-day workshop, and that's delivered in person. So that's your Suicide 101. That's really learning those initial warning signs and how to connect someone. If you're really interested in learning those intervention skills and how to support someone with their safety, I encourage you to look at an Assist workshop. Some of you may have taken these. Assist is that 2 days, and that's the gold standard. That's the real Cadillac for suicide prevention. It's an internationally recognized, offered around the world. So if you are interested in learning more, please reach out and let me know if you have any questions. I wanted to conclude, we talked about men a lot today. So some of those missing facts may have been surprising around the prevalence of suicide with men. And we talked about why middle-aged men in particular. Chris and I were talking in the lead up to this presentation around one of the campaigns or initiatives that the Center for Suicide Prevention is actively promoting right now. If you're interested, go to our website, buddyup.ca. This is a communications and awareness campaign all around preventing men's suicide. But you don't have to be a man to be involved. Women are invited too. So all of us can participate. But this is really around supporting a man in our life that we may be worried about. It's our partner, our brother, our dad, cousin, uncle, whomever it might be. Really reaching out and supporting, connecting men and encouraging those genuine, authentic conversations between men, for men, and with us as well. So buddyup.ca, I really encourage you to look at that if you're interested in learning more around men and why and how we can help men. The Buddy Up guide is very similar to what we talked about today. So if we're worried about someone, how do we reach out? If we're worried about a buddy, if we're worried about a man in our life, we can pay attention, we can start the conversation, we can keep it going, and then we can stick to our role, which is around that supporting and connecting, recognizing it's not up to us to solve a problem, but we can help connect them to that source of support. It's a great campaign. There's lots of ways to get involved. We've got lots of great swag too. You can get involved as an individual or as a group or as a campus. We support you with communications materials. So there's infographics and posters and toolkits, but there's also some really neat things. We have some stickers and air fresheners. And that's all about a visual prompt. So I've got many stickers on my workbooks here, but it's, prompting conversation. So if someone sees that stickers, buddy up, what's that about? Or we heard from the men in our advisory group that conversations between men can be challenging face to face. So we don't want to make eye contact, but we can talk in a car, for example. So we came up with this concept of an air freshener. So putting an air freshener in your car as a way to prompt that conversation, to be a visual message, a visual prompt. There's a challenge too. What would any campaign be without a challenge? So typically in the month of June is when we host this, but we are exploring ways to do this throughout the year. So Buddy Up Challenge is really encouraging those positive steps. So how are we looking out for ourselves and our buddies? So this was the bingo card, the challenge card that we did this year, but we're going to be adding on to that and augmenting that as we go forward as well. And there are prizes. There are some really great prizes. Thank you all again for tuning in today and supporting suicide awareness, particularly in the month of September, when we do try to shine that spotlight on this issue. I want to conclude with three main messages. The one is we don't have to be professionals to help support someone we may be worried about. There could be a role for a professional, absolutely. But to support and connect someone, to pick up on their invitations, we don't have to be that professional. We talked a lot about help offering. So really encouraging people to seek help when they need it, but they may not always be able to do that. So how do we offer that help? How do we skill ourselves to be able to do that? And we really believe, and particularly in these times, that suicide is everyone's business. We all have a role to play in preventing suicide in our communities. Thank you so much. There is my email. If you do have any questions or comments, if you want to learn more about getting involved with some of our initiatives or some of our training and workshops, if you have questions around those, please reach out. We always love your questions and comments. And thank you again to Chris and the Center for Innovation, Campus Mental Health. I'm also really involved with the healthy campuses in Alberta. And yeah, as I say, it's a passion and I really believe firmly in it. So thank you all so much.
Thanks so much for all of the preparation and time and care and attention you put into this presentation, Hillary. For me personally, I think it was very impactful, not just what you shared, the awareness that you brought to it, but I think the inclusion of a lot of very pragmatic considerations we can take in our day-to-day life to actually do something about this is really important. Before wrapping up, I want to open up the floor to anyone in the audience to feel free. I see a few comments coming into the chat, thanking you for the great information and the presentation. If anyone has a comment or a question, feel free to drop it at this point in the Q&A. And I'll just wait a brief moment to see if anyone has anything they'd like to ask.
Thanks, Chris.
Well, you know, I'll leave it there.
Okay.
Again, thank you so much, Hillary, for coming. And I don't know if you want to just maybe put the how to reach out to you up on the screen one last time for a moment, and we'll just sort of wrap up on that point.
Sounds great.
And to everyone in the audience, thank you for taking the time out of your day to be here today. I know September is always a really hectic month on our campuses, and the fact that you made the time to be here is greatly appreciated. Just a reminder to everyone who is in attendance, who might have had someone that wanted to come but didn't have the time in their schedule to make it, we will be archiving the recording of this up on our website. That will be sent out with a follow-up message from your attendance, or even if for anyone there who registered and wasn't able to make it. So there will be other opportunities to access this content and further connect with Hillary to follow up. Thank you.
Thanks so much again. Thank you. Thanks for all the comments.
Okay. Have a good day, everyone.
Okay. Take care. Talk to you soon.